CKD by Dr. Santosh Varughese, sir. Dr. Santosh Varughese is professor at CMC Vellore. He is the fellowship supervisor for the Welcome DBT project on IgA nephropathy. Sir has more than 2 decades of experience in teaching. He is the co-investigator for the Global Ascertain trial and PI of the TUMI trial. Today's talk is on updates on medical management of CKD. We welcome you, sir.
Thank you very much. It's always a joy to be back in medicine, where I spent many sleepless nights. And some of my colleagues are in the house, and I'm grateful for their presence. And thank you to the organizers for this kind of invitation. As in the previous times, the topics given to me are quite voluminous, so I'll try to cut them down and speak only the relevant ones and only a few of them. So the updates I'm going to cover are what can be used for preventing or slowing progression of chronic kidney disease and prevention of the treatment of complications. To the young members of the fraternity of medicine who are listening in person and online, why renal medicine is exciting, I can't miss this opportunity to say one word about our specialty. It's a lot of good internal general medicine, as well as good old-fashioned common sense. So anyone who's interested in these aspects are welcome to nephrology. Okay, now coming to the topic. From a long time, it's been known that the reduction of proteinuria or presence of proteinuria portends a bad prognosis, and therefore reduction portends an improvement. And this very old study showed that presence of even 1+ proteinuria, albuminuria on dipstick, especially if compounded with a low estimated glomerular filtration rate, portends a poor prognosis in terms of progression to end-stage kidney disease. And therefore, we all know that both for diabetic and non-diabetic kidney disease who have got any albuminuria, we give them an ACE inhibitor or an angiotensin receptor blocker with a run-in period to look for hyperkalemia and up to a 30% increase in creatinine. Although it's been known that the combination of ACE inhibitors and ARBs do work together to reduce proteinuria better than either of them alone, combination does not seem to benefit in actually reducing the progression of the disease. And 2 large studies showed that there was hyperkalemia and AKI, but a caveat is that they were done in elderly Caucasians. The average age was above 60, and they were used at maximal doses and not like we would use clinically. And therefore, if you're forced to use in somebody who's not responding, we could add the 2, although we'll be careful about hyperkalemia and watch for it and use the sick day rules as applied. So then came the advent of the new drug that we use very commonly now, the SGLT2 inhibitors, which is the first class of drugs I'm going to think about. It blocks the reabsorption of glucose in the proximal tubule, lowers renal glucose threshold, causes glycosuria, and the subsequent natriuresis reduces intravascular volume, blood pressure. The increased distal delivery of the sodium normalizes tubular-glomerular feedback and decreases the glomerular pressure through constriction of the dilated afferent arteriole. And this has shown to reduce albuminuria and progression of CKD. The threshold for its use was initially 45, then came down to 35, 25, now they say 20. But I must tell you that I've used in several patients with a GFR less than 15, and the drug does work. But always you must have the run-in period and make sure that they're tolerating the drug. I will not discuss this slide except to show that the normalization of the tubular glomerular feedback causes the afferent arteriole to constrict again and reduce the pressures in the glomerulus. So the major study in this was the DAPA CKD trial, which was published a few years ago in the NEGM, where they gave dapagliflozin or placebo, and 2/3 of this group had diabetes. And what they found was a composite of sustained eGFR decline, end-stage kidney disease, or death from renal or cardiovascular disease was overwhelmingly either together or separately for those who got the dapagliflozin. This shows the same thing, showing all the good features for DAPA compared to the placebo. This is again, it's not it's a class effect that was confirmed by the use of empagliflozin, published last year in the New England Journal of Medicine. Again, showing that progression of kidney disease or death from cardiovascular causes was favoring the use of empagliflozin, and has become a current common drug that we employ. And the benefit seemed to be most with those who are most proteinuric. So the most proteinuric they were, the better the response. This is a slide showing the same thing. These and other trials were together analyzed by the Lancet and showed that the risk of acute kidney injury in those patients, risk of cardiovascular death, hospitalization, cardiovascular death alone, those with diabetes or without diabetes, irrespective of the baseline eGFR. And initially, there was a lot of worry about amputations and ketoacidosis, and they said that the benefits are way, way more than the hazards that are potentially involved. Switching the drug, we're going to talk about this next drug, which is talking about mineralocorticoid receptor antagonists. So as you can see, all these trials, we show that the losartan is better than placebo, canagliflozin and dapagliflozin, empagliflozin better than placebo. All these groups, placebo meaning no other drug, they were already on ACE inhibitors or ARBs. What was found, there's a lot of residual further declining GFR, which was not tackled. So using it did benefit the patient, but there were a lot of patients who still were progressing. And therefore, the next couple of slides are actually borrowed, they're not mine. They came up with this idea of reducing inflammation and fibrosis by tackling the mineralocorticoid receptor with the new antagonist as opposed to epinephrine or spironolactone, while finerenone. It has important structural differences, especially with its selectivity for mineralocorticoid receptors, short half-life, and most importantly for us, less hyperkalemia. So there were three major trials looking at kidney outcomes, cardiovascular outcomes, putting them both together, termed Fidelio, Figaro, and the Fidelity. And they're just to be confident, they used huge numbers. You can just looking at the list, they've used close to 13,000 patients in their trial, making us confident that the risk of hyperkalemia, especially if you look for it and exclude it, is not that bad, and we can use this drug. And they were used in patients who are either having moderately or severely, or even more than that, albuminuria. And I'll just show the inclusion criteria were diabetics, adults, who are on maximal tolerated doses of ACE inhibitors or ARBs and who did not have hyperkalemia. They show the results. They published in the New England Journal of Medicine in 2 subsequent years. I'll show both the results of the trials together. The trials showed a benefit in the composite of kidney disease and a sustained more than 40% decline in eGFR favoring finerenone, or secondary kidney composite outcome of doubling of creatinine or 57% increase in decrease in GFR. And when they looked at the which groups they favored it, primary outcome, of course, was favoring the drug finerenone, as well as a secondary outcome. The most important benefit they found was reduction of albuminuria, which we know is the target which everyone followed. They also showed the Fidelio group of it trial showed the composite cardiovascular benefits of time to cardiovascular death or non-fatal MI or hospitalization. And the hyperkalemia was not much. The mean potassiums of both the groups when they were on diet and on ACE inhibitors or ARBs was actually exactly the same, around 4.5, give or take a few. The follow-up period of 3.4 years, they showed that there was a composite benefit and main benefit was seen in hospitalization for heart failure in these diabetic kidney disease patients. The benefits were of doubling of creatinine was seen in this group as well. And when they looked at who benefited, apart from the primary outcome being positive, beneficial hospitalization for heart failure, sustained decline, it was touching 1, and more than 57% or doubling of creatinine also was touching 1. When they looked at the mean change of potassium, the discontinuation was slightly more, but not that many in terms numerically. So we check for a rise of potassium in these patients if we use them. The adherence was high, and there was not much effect on blood pressure compared to spironolactone. When they looked at the drugs, all the data together in the Fidelity, they showed putting the data together showed a better picture of better composite outcome for cardiovascular as well as kidney diseases and hospitalization of heart failure. They found that when you look at the groups that benefited, there seemed to be, the mortality did not seem to be much affected, but apologize for this, and death from cardiovascular diseases. So the investigators looked at the as-treated analysis, and for whatever it's worth, they put out the data that the as-treated group, there was a benefit on mortality as well. So the news is up for grabs. May need more data to show it. Again, the predominant benefit was in albuminuria. The subsequent analysis of the same data showed the decrease of the change of albuminuria from baseline was more reduction was more marked with finerenone, as well as it was again in patients who had more the albuminuria, the better the response. And with there was a time of progression also of our developed albuminuria also was favoring the use of finerenone. They showed that this may be an opportunity for people who have EGFR of 75 and who got albuminuria to reduce the cardiovascular disease risk. And therefore, the guidelines subsequently, many of the guidelines have incorporated the use of finerenone in their guidelines with time. And there's a small trial, large trial is going on combining SGLT2 inhibitors and finerenone. There's a small trial which is published this year. And there is only 20 patients whom both group got finerenone and DAPA one at a time. And a combination of two showed that the cumulative effect was in a better decline in protein albuminuria. There's also signal towards a more decline in EGFR also. So we are waiting for the major trial that is undergoing now, being carried out now to know what is the truth. But there's seems to be an additive benefit, more than additive benefit on albuminuria reduction. The next drug, which has been around for years and years, is use of sodium bicarbonate to correct metabolic acidosis. The trials have found that using sodium bicarbonate to aim at 23, not very high bicarbs, reduces the risk of end-stage kidney disease, rate of progression of disease, and annual decline of EGFR or T3 with use of bicarbonate. And the subsequently again shown there was mortality benefits and the risk of renal replacement therapy in addition to doubling of creatinine. As you can see, the graphs are very different at the end of 3 years, including mortality and requiring of dialysis. There was no increase in blood pressure, which was the concern of giving sodium molecule. There was no increase in blood pressure, no body weight or hospitalization rates increase. And there were 2 trials showed that there was a benefit in those who did not have acidosis. So they're saying that even if the bicarbonate was 23 and more above, we could give them bicarb, and there would still be a benefit in terms of the progression of disease. A very interesting study came out a few years ago on AV fistula creation and EGFR decline. Very controversial study was done using the large database in Montreal. The senior authors, one of my former colleagues, in fact, I met her a month ago and I asked her about this trial. So they had 3 groups of patients. One group of patients who were on peritoneal dialysis who did not have any hemodynamic fluxes during dialysis, so the EGFR decline would be as before. The patients who had the fistula preemptively created, and there were patients who did not have a fistula and they were being followed up. And interestingly, the patients who had a preemptive fistula, their EGFR decline was much slower than those who did not have a fistula. And therefore, that has led to people thinking that maybe an earlier construction of fistula in the patients likely to require dialysis may actually slow the disease. How this happens, people have postulates, but we really don't know. And there was a meta-analysis done showing a few studies. Major one was this one, and showing that although the data quality was not very good except for this data, there might be a potential added benefit. So for whatever it's worth, we advise a fistula a little earlier than before after this trial. The next class of drugs which came out was use of sodium zirconium cyclosilicate as well as patromer, which are oral potassium binders. We know that we can't use things like sodium or calcium polystyrene sulfonate long term. So these drugs have come out and they've entered the guidelines in that now when we find hyperkalemia, when we initiate ACE inhibitors, ARBs, rather than taking them off, rather than taking off the wonderful drug that they require, they say add this cation exchanger, which is not yet available in India though, for a benefit. And the guidelines have now incorporated saying that you include that, and they said initiate treatment with potassium lowering agent and don't stop the ACE inhibitor, the ARBs, unless the potassium crosses 6.5, which is very different from what we would do in clinical practice. So between the two drugs, the sodium zirconium cyclosilicate seem to be a faster onset of action with rapid control, but both drugs are quite good. Another point I want to just mention as we go along is the use of lipid lowering therapy. The chronic kidney disease patients for 50 years and above, because of the rate of risk of coronary disease or non-fatal MI is high. The guidelines now suggest that everyone above the age of 50 don't check their lipids. There's no LDL target to follow. Just give them a lipid lowering pharmacological agent. And for those younger, based on their risk, and probably when the age touches 50, we can add the drug as well. One of the changes that have happened is in the field of anemia. I'll talk about iron deficiency anemia, which is common, and the treatment is not without debate. I personally am quite concerned about giving intravenous iron because of the risk of hemochromatosis. If you do MRIs for patients who are otherwise not having obvious disease, we find iron deposits in the heart and the liver. So I'm a little concerned. But for the public draft form of the new guidelines, came out this month. It's not yet out in final print. So the guidelines now are going to suggest that for those with ferritin of 100 and transfer saturation less than 40, or those with ferritin above 100 and transfer saturation less than 25, we give them intravenous iron. And the treatment is now following the proactive treatment compared to the reactive treatment that we normally used to do, seeing the values as shown in the pivotal trial, which I'll show in a couple of slides. This all came out because several RCTs, observation studies, show that patients actually tolerate higher doses and require less erythropoietin or its equivalents and transfusions. So this last trial published a few years ago in the New England Journal of Medicine called the pivotal trial, and patients on dialysis giving intravenous iron, they used very high ferritin targets of 700 and a transfer saturation of 40. But what they found is there was much less requirement of injections of erythropoietin and less transfusions. That means that they did have some occult, if you were to use the word occult, iron deficiency anemia that we were correcting. And they seem to be well tolerated, and some had some possible secondary benefits as well. The other anemia treatment, which is the last thing I'll talk about, is the use of HIF-PHIs, class of which is roxadustat. The class came in, why take injections when you can take oral drugs? And the studies which compared roxadustat to erythropoietin alpha as one of the drugs showed there was no difference between use of roxadustat as erythropoietin alpha. And in compared to placebo and non-dialysis patients, no surprises, there was improvement in hemoglobin. And they did the study in multiple trials, all showing equivalence with erythropoietin and benefit against placebo. They got, I will not detail all the trials except to show there was a major benefit compared to placebo and equivalence compared to use of erythropoietin or darbepoetin in the different molecules. And they also seem to be working quite better in patients who had elevated hsCRP indicating underlying inflammation. So there were a lot of drugs, trials all named after mountains, all showing the benefits and not much MACE effects either. So I won't go through all these slides. The similar trials were shown showing benefit with drugs like vadadustat. I'll just skip, and then dialysis and non-dialysis patients, and daprodustat, and the last is the desidustat, or what's called the desidustat, which is developed in India, showing that the benefits of hemoglobin response equivalent against darbepoetin, both in dialysis and non-dialysis patients. There were a host of studies which have come out now, listing non-dialysis as well as in dialysis patients, showing equivalence of their use. Of course, there are some debates about potential side effects which we need to watch out for, which we'll not discuss now. So the meta-analysis shows a benefit in these patients in dialysis and non-dialysis patients in correction of anemia, and therefore it's a welcome alternative to injections in these patients, especially those who are not on hemodialysis, and those on peritoneal dialysis, and those who are not yet end stage. This is a wonderful drug that people can consider in them. albeit we need to follow up and for more data. The dosing, depending on the drug, the one in red is the one that's available in India. You can either use alternate day or thrice weekly to target the hemoglobin of 10.5 or 11 to 12. So in the last 20 minutes, I've talked about SGLT2 inhibitors, how it's changed the landscape. Finerenone is a very good drug. We're not yet using it because of its cost concerns. Sodium bicarbonate, easily available, very cheap and easily doable. Preemptive arteriovenous fistula creation, which we've begun to enforce a little bit more. New phosphate binders to treat or prevent hyperkalemia, not yet available. Use of widespread lipid-lowering pharmacotherapy, which has become guidelines, and deficiency anemia targets, which personally I have a little bit of a hesitation using, but we can give larger doses to target higher ferritin levels and correct the anemia better with reduction of transfusions. And the new kid on the block, the HIF-PHI class of drugs. Thank you very much for your patient listening.
Thank you, Santosh. I'll ask